So here's the agenda for today's webinar. We've introduced the webinar, and now the next thing is to introduce the guest speaker who is on ground. Next slide. So, but before I do that, I have a good news to share with you all. We've been having this webinar for a couple of months now. I mean, uh, it's been an amazing journey. It was just in a room with Alosh and I thinking about, okay, what can we do to engage the community? You know, we came up with the name and the acronym ALIBSA. It was like several months ago, but we started the first ALIBSA webinar was in February 2023, and we've had series of monthly webinars. We've had great feedback as well. But we recently got funding, and the funding would help us to have our first in-person ALIBSA annual congress. We hope that this will be done every yearly. And the proposed date is on the 1st of July at Watershed Bristol City Centre. For those in Nigeria, pardon us, probably when we are financially buoyant, we can get you your tickets to come in to attend future sessions. But this will be delivered in person. This will be the first event. And the team and the aim is to create a platform to enable our stakeholders, our potential stakeholders, to engage in, health-related issues. So it's all about stakeholder engagement for this year's team. So further updates will be shared, but I just want to share that with you. Next slide, please. And so now I think it's now time to present our speaker, who is Dr. Janet Ige Elegbede. I would love to, especially thank Janet, because in the past we've had cause to invite Janet, and this is our second time. Thank you so much. But before she starts, I want to introduce her as a seasoned, academic researcher and a public health practitioner. She is currently a public health lead at Slough Borough Council. She has over 8 years experience in population health research. She combines a passion for embedding evidence-based practice in her role as public health lead at Slough Borough Council. So permit me to open the floor for Dr. Janet. Thank you.
Hello,
Over to you, Janet.
Thank you very much, Tia. It's really nice to be here. Thanks for inviting me again. And thanks to my colleagues. I can see a few of my colleagues here as well. It was really a last minute message I sent out, but thanks for those who were able to hear. And then everyone else here, nice to meet some of you for the first time, and hopefully we can get to talk a bit more on this session. So I'm just going to share my screen, and can you confirm if that has come up? Yeah? Great. So today we'll be talking about overcoming the barriers to cervical cancer screening among people from Black, Asian, and minority ethnic groups. Apologies, my voice, you will see, I think Fatia mentioned that there's a bug going around, and I'm afraid it has gotten to me, but I think I'm at the later stages of it. Good thing we're not in person. Hopefully by the 1st of July, I will be a lot stronger. I'm not going to spread anything.
Absolutely.
Yeah, great. So, well, I know we've done a bit of icebreakers, so I'm just going to skip this one on how are you feeling today. We've all talked about how the weather is a bit rubbish, so we can stop moaning about that maybe. So I'll just move on to the next slide, which is really to focus us on what we're talking about today. We can't talk about overcoming the barriers to cervical cancer screening without understanding what the barriers are, or also understanding what the impact of screening is and what screening does. So I thought I'll give an overview of screening, the purpose of screening. I'm sure a lot of us are aware of screening already in terms of whether our role or being invited for screening programs. So we'll have a bit of interaction around that. And then I'll talk about some of the barriers from, give us a chance to actually tell us some of the barriers that you are aware of. And we can begin to think about what potential opportunities to address those barriers. So I don't have the solution is what I should say, just up front. I think we will come up with kind of suggestions on what we want to do So the idea of screening, I'm sure you're aware. I mean, I can see there's lots of professors and doctors and medics in here. So sorry, apologies. This is really basic. But I thought it would just be helpful for us to think about what the aim of screening is. In terms of being able to identify people who will benefit from further intervention and tests, to be able to identify diseases at a very early stage, or identify risk factors of diseases at very early stage. So this diagram here, or chart or picture, talks about the stages of what screening does. It's, you've got a whole population, you've got a subset of the population that are eligible for the screening based on perhaps the screening program's definition. And then these people are invited for screening and they have the screening. You have people who are negative. Screening detects that, you know, there's no issues at all. And then you've got some set of people who the screening detects a positive outcome, which means that they do need to kind of go for further tests. And that further test might end up finding that they are negative, which will be great, or it might find abnormal findings, which will necessitate further test or disease development. For the disease development is to see if actually they have the disease. And then there might be some people who are not, you know, the result is not conclusive. But the aim is that we are able to intervene. And some of the outcomes from screening, you find some outcomes which, I mean, the top two are kind of like what the goal will be, that, you know, the outcome is better because of early detection. So the people have not developed the disease, and, you know, we've been able to identify the risk factors, been able to give them lifestyle advices, and probably signpost them to interventions. But you might have situations where the outcome is good, maybe, but the early detection did not make any difference. So it might be particular to the disease condition. And the other two as well, thinking about whether the screening will have an impact or not on the disease. I think the last one is probably it's not as common, because before a screening program is introduced, there is a lot of research that goes into understanding the benefits of the screening program. And we can't be implementing screening programs if we are clearly certain that it would have no impact on the disease. So I said earlier, the purpose of screening is prevention of the disease, or primary prevention. So in the case of cervical screening, identifying the HPV virus to see if they've got an high-risk HPV virus, and if they need to have further tests. But also secondary prevention as well, in terms of early diagnosis, and so that there isn't any further complication and spread of the disease. So over to you now. Sure, a lot of us, if you're female in the room, and not just females, I think all of us will probably, if we haven't heard of it, at some point in our lives, we will hear of it. So I just want to throw it out to everyone to give me examples of screening programs that you're aware of. I think there is a chat function here.
Yeah.
Yes, so if you want to put in the chat box, or you want to contribute, I don't know if there's a raise your hand function. I think there is,
I think, yeah,
yes.
there's a raise your hand function.
Brilliant. Okay, Maddie. Yes, great. Good news, Janet. Oh, you're my namesake. Yes. Brilliant. Yes, great. So we have quite a few people who have, yes, Kilele, yes, breast screening. Alosh, yes. Yes. Yeah, brilliant. So that's quite good. Do you know, I mean, any screening programs for children, or, you know, babies, or anyone aware of that? I'm just trying to kind of let you understand the fact that screening is not necessarily, you know, from adulthood. We have been, I mean, we have fetal screening programs. And if anyone has had a baby, in the UK, certainly, but I'm sure also in other countries, Nigeria, you would have discussions with your whether midwife or your health team who are looking after you for your antenatal, and there will be opportunities to offer you screening. Thanks, Tia. So you have Down syndromes, and there's a lot of them. There's Peteus syndrome, Edwards syndrome. There's quite a lot of tests that are done. Some of them are 20 weeks. Yes, Abolale genetic screening. Yes, brilliant. But even after the birth of the child, in the UK, certainly, you do also have like a hearing screening. And yes, Kilele, yes, spot on. You read my mind. So yeah, newborn hearing screening. You can tell Kilele is an experienced dad. Um, so those are opportunities that so screening starts really from the pregnancy, and the idea is that we want to catch things before they become problematic. Thank you, Abolale, metabolic disorder screening. Brilliant. So we are not, this is a topic that we are fairly familiar with in terms of the concept of screening. Lydon, yes, that's my colleague. We share the same role, looking at so slightly different areas, but breast screening, bowel cancer screening, so it's put everything in there, Lydon. Thank you for doing that. Not all of them are cost effective. That's a good point. And it comes to the point about why you offer screening programs and who you offer them to, and defining your population. Because if a screening program is really expensive and it's not particularly about sensitivity and specificity of the screening, and sometimes screening programs are targeted to specific populations that we know are of very high risk, in that way to lower the overall kind of, to improve the overall cost effectiveness. Thanks for mentioning. So I know I've got a lot of people to answer questions when the questions come. So don't run away when I throw the questions to you. So the next slide is to talk about the importance of cervical cancer screening. Now, we know the cervical cancer is the fourth most common cancer among women, and over 640,000 new cases of cervical cancer, and the deaths are a lot higher in LMIC context. So if you see that nearly half or even over half of the deaths of the number of people who had the new cases resulted in deaths in 2020. So the burden is a lot higher in LMIC context. So let's talk about African countries, South Asian countries, Southeast Asian countries within the low middle income bracket. Can anyone tell me, guess, why do we have a higher burden of deaths from those contexts, and higher prevalence as well? Why do we have a higher prevalence and higher burden of death from those countries? Anyone want to unmute or? Yes, brilliant, Alosh. Yes, thank you. So it's the fact that the screening program in those contexts, sometimes I don't necessarily think that they are particularly affordable or accessible to the most of the population, or even that people are aware of it. And so we'll come to that in talking about the barriers, because I realize obviously on this call we've got people from Nigeria, we've got different people here, the UK, we've got a representation from Cameroon. So we won't really, I mean, my slides are a bit focused on the UK, but we will talk sort of more globally. So it's quite important. Thanks, Lydon, and thanks, Toby. Inadequate information literacy, access, awareness, screening, fragmentation due to this is COVID-19 etc. Yes, brilliant. That's really important. So when we talk about LMIC context, there is a lot of things already that are going on, with regards to, I mean, communicable diseases are quite easy to understand. They can see them. And then there is a lot more awareness about infectious diseases as opposed to sort of long-term chronic conditions that people will not see until probably a bit too late because they develop symptoms. In the UK, it's still an issue, but you can see the numbers there, 3,200, and the number of deaths. So this is a bit old data. I should have updated this. But you will see that death rates are not reflective of kind of like nearly half of the population in terms of the global statistics. So in the UK, we had a national cervical screening program, which was implemented in 1988. And this led to a reduction in over a third of the cases. I have explained the whole idea of screening, as you can see in the picture there. And I think Alosh has also talked about the fact that women aged 25 to 64 are invited for cervical screening here in the UK. They would receive invitations generally if you're between 25 to 49 every 3 years. And if you are 50 to 64, you will get it every 5 years. And the aim is to identify HPV and infection and to prevent, cervical cancer by early detection. And we know that early detection increases the chances of treatment. So we just want to talk a bit more about, thanks Giselle, about uptake of screening among people from Black, African, and minority ethnic communities. So we know that there's disparity in uptake according to ethnic profiles. Women from South Asian backgrounds are 32% less likely to participate in cervical cancer screening than white women. And in the UK, at least, there's several measures that have been taken to encourage participation in screening. I know we talked about LMIC context with regards to awareness, but here people will be getting the letters. Most times when a woman turns the age of 25, well, it might not come that same year, but it's already in progress. They get a letter sent to invite them. The GP practices send reminders, text messages, and you've got some places where they're actually even offering evening appointments and weekends appointments to kind of make it a bit more accessible. And so there are those measures that you probably would not find in Nigeria, for instance, in terms of the proactiveness of encouraging uptake of screening. So I guess my next question is, either from a UK context, from a Nigerian or a global and Asian context, like a country, what do you think are the barriers to uptake of cervical screening? I know we mentioned some, but basically looking at the LMIC context, but what can be the barriers? I mean, especially in the UK, for instance, when you've got the text messages, you've got the reminders, but we know that people from sort of predominantly white groups are accessing screening more than those who are from Asian, African backgrounds. So yeah, let's keep it coming. I can see a few comments in there. So I said at the start that we're going to do this webinar together. We'll come up with the problems and we'll come up with the solutions. And my role really is, just keep the comments coming. My role really is obviously talking about the evidence. So I've got a passion for research around looking at minority ethnic communities, and I've done a lot of research on barriers to health promotion among those communities in the UK. So what I will be doing, in addition to what you've just put, is to kind of validate what we have said with, yes, the research says that. So brilliant. So I can see some comments there. Anyone want to come in, put the voice to the name there and just say something? I will read the comments, but just opening the floor for anyone who wants to unmute their microphone and say something around this.
I think language is also one of the key issues that suppose, because in the letters, etc., that I just got a letter from NHS for a screening for something else. So the language there is all about, it's very dry and clinical. So just to understand that and then just to go there, it just takes a lot of motivation. I think language, even in English, the language they use is going to be, I think, is an issue. But especially if English is not your first language, it's going to be an even bigger issue, I think, how they speak and how they talk in their letters, etc.
Yeah. Brilliant. That's really useful. Thank you. The language, and I think that's linked, yes, to in terms of the diversity in the community. So when people, are not able to understand the jargon,
Yeah.
perhaps, or even understand the benefit, it's not clear, it's not plain, it's not accessible, or they don't even understand English language, and then you've written a letter with everything in a text that they can't understand. So that's really good. Just in the interest of time, just going to move and read some of the comments here. Yeah, Toby, comment. Yeah, I can see your hand.
Yeah, I was just gonna just mention the cultural and the religious belief really, but everything still goes alongside with the ignorance, that lack of understanding of what the subject matter really is and what it's about. So I guess if people have access to information and they understand, then
Really.
it
Do you
can
want to
help.
talk about the religious
Oh well,
impact?
basically, I think we might actually have our reservations about our female wards, going into hospitals, like taking the smear tests, stuff like that. I don't know, it takes a level of understanding to actually go on ahead, especially when it's about the female folks, about taking the smear, you have something being inserted into your parts and all, you know. So it really takes deeper understanding of what the subject matter really is to actually go beyond this.
Understand? I mean, yeah, great. So I don't know. I think you were cutting out, but I think I got the gist there, which is really really useful. We'll come to that. That's really helpful. So we've got religious, cultural belief, lack of transportation, which is access, cultural beliefs, fears of the unknown. Yes, this is a very important one. People, I've obviously come from Nigeria, where what you
Mhm.
don't know will not kill you.
Yeah.
In a way, there's a slang about that. That if I
Mhm.
don't know about it,
Mhm.
then it's not going to bother me. But what that is, it's one of those things that is a driver of a premature mortality, because that prevents a lot of people from actually being able to act on things that they could prevent. So while I was in Nigeria, I used to work and do a lot of HIV/AIDS awareness campaign, or testing, and lots of people were just running away from it because they don't want to know their HIV status, because they feel like if they just don't want to know. They don't care about knowing, because it's like knowing the unknown or the taboo. So yes, it's really really important that we address things like that. Stigma, yes. Concerning who conducts the screening, yes, absolutely spot on, Maddie. And ignorance, lack of understanding on the needs. Brilliant. So just in the interest of time, these are kind of exactly the same things that we have said. And I said I was only going to say this is what the evidence says. So we are in line with all the evidence is saying, and obviously emphasizing some of them. It is about the knowledge, about the importance of cervical cancer screening, misconceptions, about how often. So someone might have done a screening a while ago, and then they think that that's it. I've done it once, and that's it once and for all. And also, there is also the thing about the evidence just about screening and promiscuity, in terms of people's perception that if you go for that, that you've been doing something. That's why you're if you're faithful, if you're not, if you're abstaining. And we know that in African context, sex is a taboo thing. If you're not married, to many of the religious groups. So there is that part of screening and family support and around that. So cultural, we've talked about this. There is a belief of religious traditional approach to things rather than a medical approach. We talked about taboo topics, talked about language, and Aloysius mentioned that. So literally what I'm just saying is that the evidence suggests, because it is, the evidence is drawn from interviewing people like you and I, and people who have not, access screening, and asking them why. There is also one part which probably haven't talked a lot about, is the distrust in the healthcare service. Now, working in the council has kind of opened my eyes to a bit of things, because I've worked with people, populations, and I clearly have seen a lot of conversations around a lack of trust with, in terms of healthcare or health professionals, or, what are they going to use the data for? I am not a legal citizen. I'm not legal in this country. They're going to report me. They're going to deport me. There's a lot of mistrust. There's a lot of things that can affect people from coming up, going for screen. Thanks, Lyden. So there is, and most of this is perceived discrimination, not actually the real discrimination. Not that people have gone for screening and then and then after the screening, Home Office is waiting for them to take them to detention centers. It's really the perception, and negative news, things that, they travel really fast, really quickly, and one person says it and it spreads. So that's really one of those things that we need to kind of think about, how we build that trust and bring things together. I mean, in Slough, some of the things that have been happening now is that we've got colleagues in the GP practices, leads of primary care networks, going to speak to communities, to speak to people, make themselves accessible, and they are members of the community. So it's really great seeing communities, GPs from BAME communities, Asian, South Asian, Blacks, African, speaking to Africans, telling them, well, this is for you. This is, addressing those questions, and then people are able to open up and ask those questions that they think, those misconceptions, that you can then address them. Because if you don't voice them, you just carry them on. And if you are speaking to a certain type of or certain person, you might think they'll be judging you and you don't want to talk about it. But when you feel like you're in a trusted place, then you voice those concerns. So it's really giving those people opportunities to talk about the concerns, and then we address them. So we talked about accessibility issues, so I'm not going to dwell on that. So I guess we'll finish off on this 2 slides, I think, in terms of what can we do? What can we do as practitioners? What do you think? I mean, if you are not a practitioner, what do you think a healthcare practitioner or the local authority should be doing to help improve access to screening? And I'm really glad that my colleague Kilele is here, because he is our lead for screening in Slough. And we know that we have a particular problem with screening uptake among South Asians and Black African communities. So we're going to be giving Kilele action point, what he can be doing and what we can be doing together as a team. So if we can put that in the chat, what should the council be doing? What should we be doing, and what should healthcare professionals be doing to help us address? So we'll talk about what needs to be done from a practitioner point of view, and what needs to be done, I guess, with the communities as well.
Yeah, can I talk?
Yes.
I think reaching out
yes.
to the community is key, engaging them in whatever you do, in terms of ensuring that you let them know that you are part of the community. So in terms of establishing a network, a relationship with the community would build trust over time. That's one. Another way to go about is platforms like this, the awareness, because a lot is, I mean, there's a long rope to pull when it comes to influencing people's perceptions about the process. I mean, personally, I got scary about cervical cancer, although I'm a medical doctor, and it took me a lot of effort to get my cervical cancer screening done for the first time. So I'm looking at the perspective of being a medic, an educated person, someone who is aware of the risk involved in having cervical cancer, and looking at mitigating measures to overcome that. Not keen to go through that pathway, now relating it to someone who is not educated, who is from the ethnic minority background. And believe me, most women from the ethnic minority background or from the Black community are modest when it comes to exposing themselves to someone else. So I think the whole process needs, I don't know, if probably in the future they could use blood screening, but for now it's not about cervical screening. The whole process is scary, I mean, to most women, and I feel that level of awareness and building the trust, which would take a long time, could help. And Alosh did mention about the information leaflet, the language itself, the way you communicate whatever you want to do to your audience, is key in getting their engagement and their participation in whatever you're proposing to do. So I think that part of health education when it comes to cervical cancer screening is missing within these communities. And even within the healthcare practitioners, we have less representations of this community, this ethnic minority communities. So a Black woman will prefer you examine her genet than someone else. So that level of representation, inclusivity, diversity within the healthcare practitioners is also key. So I'll leave it for others to
Brilliant.
comment, as
No,
I
that
think
is really good.
that's up in my
Lots of
hand.
good things there. Yeah, lots of really positive things there, good things that we can take home from there. Lydon, yeah, do you want to come in?
Very, very briefly, I mean, it's a good theme, and I echo what Fatia was saying, because if medical and professional healthcare someone is feeling like that, then fear is coming top of the list. I think I listed fear uh, in that order. Why is that? Because we know what is happening. We know in terms of, it's not the access is not the first one, is the knowledge and awareness. So I think it might be very useful, and I did put something on the chat, but I think it's very useful. And we have seen the hesitancy with vaccines, with other things. The best, or one of the best ways of tackling it is, maybe helpful, to book an appointment with your GP practitioner to discuss it, to talk through what will happen during the test, how painful it is, the ways that they can make it somehow easier, ask the questions, and make sure that you know everything before going to the next step. The same story is we need as health professionals. Kilele is there. Janet gave a good presentation. The barriers are most of it. When we're talking about something, you can give as many data as you want, discussing the preventable deaths, discussing where the whole trends are going, but nothing is left with someone that is asked to have the test done. The only thing that would bring them forward is to build trust, as we said, to discuss it with those that are close to communities,
Absolutely.
voluntary sector, anybody else. So it's just going down there in the roots and finding out if it's a language barriers or other things like fear, and then tackle them one by one. And we will see things will improve. I hope Janet would agree with that. I don't want to say the last
I
word.
absolutely agree
This
with
is
that,
some of the
Lydon.
things that we have learned. Without those, yeah, cool.
Yeah, absolutely. I think there's nothing new here. I'm not presenting anything that we don't know. And I think it's great that we already know that these things are existing. And I guess the challenge for us is, why are we not doing this? I guess is, and we can come to that. But I absolutely agree on the fact that we need to understand our communities, and we need to work with our communities in a way. So the way you work with a community of, say, African women might not necessarily be exactly the same way you will work with another community. So it's really understanding your community and working with your community. So I guess in terms of what the evidence says, like we've talked about the health literacy and having accessible information to the target audience. So really, really emphasizing what we're talking about in terms of getting the message across to people that need it the most. And I can see in the chat box as well here that we've got lots of really good stuff here about awareness, misinformation, the notion of pain. I think it's whenever you want to go for any particular test or something, even injections on, is it injection? I don't know, my daughter was going for something the other day and they were trying to explain and describe what the pain would look like, but we only got to find out that after we were there already. Whereas if women are able to know beforehand to say, because they have a kind of conception of what it would look like. And so it's trying to address those misconceptions. I'm not saying that, we won't lie to people. I mean, I attended a presentation similar to this, and one of the things that was really great was they brought out all the devices, kind of showed them virtually and said, this is what you're going to be using. You can ask for a smaller size. This is what the brush is. This is literally what it's just going to do. It's brushing, scooping. That's what's going to happen. If anything you want to stop, we will stop. But I echo what Fatia said about, if I am a Black woman, I know that I'm already going there with my heart, raised up in terms of who is going to open me up, who wants to look at me. And it's the same with Asian women. And it's even 10 times high, more in a Muslim woman, because of the discussion around modesty and the need to preserve some of those values. So it's about ensuring that we offer those opportunities for people to air their views, but also address those concerns. So targeted outreach, for instance, where you've got an awareness campaign, but you've also got people that are within those communities that can deliver those services there. And people from South Asian communities, Black communities, women, medics that are trusted, that can work with them to deliver the screening, because people hear and they say, yes, they're inspired, they want to do it. And then they go home and it's 2 weeks time, nobody contacts them. By the time you send that letter to them, it's all vanished. So we need to be more proactive with our approach with regards to that. And in terms of the public, so similar things, it's cultural understanding and local initiatives. So that is really the end, but I just wanted to finish off with just acknowledging the fact that we know that these are barriers and challenges, but I think we need to start as professionals, as practitioners, picking them one step at a time, and picking one of those major issues, say the communication, and working with in collaboration with other stakeholders to review that messaging. People are using text messages in a smart way, in languages, local languages. We can't do that. We can't try and see how we can pilot those initiatives and see how impactful they are. We can take the approach of having targeted awareness campaign, and we speak to local services that will deliver the screening, let them know the importance of having a woman from a South Asian community there, because this is a South Asian community group. They are more likely to accept to do that screening. So it is working on those examples. And I will end here for questions, but I'll pass on to Fatia.
Yeah, so sorry, Janet, you're not ending here yet. I just want to ask the audience, especially people joining us from Cameroon, Ghana, and Nigeria, can you share some of the barriers you feel you're facing right there, or you think your healthcare practitioners could face in ensuring patients or people get screened for cervical cancer? Can you share your thoughts with us? You can put it in the chat, or you could unmute. Yes, Giselle.
Thank you very much, Dr. Fatia, for the question. I think the barriers that people face in low and middle income countries like Cameroon or Nigeria are a bit different from the barriers here. They are similar in a way, but there are a few differences, because back home, they don't have like text messages or letters from the GP wherein they are reminded to attend the cervical cancer screening. So most people depend on health campaigns wherein they spread out information that there's free cervical cancer screening, because also it's not every screening, it's not a screening that is made free by the government. So people have to pay for that kind of stuff. So with health campaigns, there's a promotion about the cervical cancer screening, and the aspect that it is free also helps more people come in. And spreading the information about free health campaigns is through the news, the newspapers, through leaflets and posters outside of hospitals. And I feel like it doesn't go much into the community except through like word to mouth or WhatsApp statuses. But community outreach is low, except if the health campaigns are held, organized by local NGOs whose aim is to actually go into the community to recruit patients for recruit women or educate women on the importance of cervical cancer screening.
I think that's actually spot on. It just took me back to my days talking about HIV/AIDS, and literally we were taking the megaphone and we were in the market of, they call it Isaleko market. It is one of the biggest markets in Lagos State. You don't know your starting point, you don't know your end point. You will just So literally just shouting it out to people to say, it is accessible, and people were scared that, oh, they're going to, one person told me at the time, long time ago, that so if they test positive, there's going to, and there was unfortunately for us, there was a police van that was parked not too far from us, so there was that perception that we would just bundle them into the police van. So I think you're right in that, in African countries, it is about the grassroots, how they get the message. It's a very different terrain in that they won't get letters or postman coming to deliver it, but I think they rely on us. They rely on you and I, Giselle, who are there to be able to spread that message to our parents, to our sisters, to our brothers, to share to their wives, to get the message out there, because it's a different way of kind of recruiting people into intervention. And I think, like you say, NGOs are sometimes obviously funded, and they can afford to have people who go into those communities and do the door knocking, but it's limited. Like, for instance, you talk about the size of Ghana or Cameroon, Nigeria 160 million. How many people are going to be able to go and knock on everyone's door? So we need to be thinking creatively. Social media is another way of, everyone is on Twitter, and not everyone, but at least there's a large coverage on Twitter. There's a large coverage on other social media platforms. It's putting the message there. But like you say, people will have to pay for screening. So this is someone from Nigeria, I think, Professor.
So I think I can find a comment from Ghana. Yaira, thanks for your comment, Yaira. Yaira mentioned that there are health campaigns, but for 1 month every year. That's ridiculous. There are free screenings, and that is when people usually get screened. Otherwise, there's much patronage for cervical screening. Thanks. That's in Ghana. I mean, that's quite different from Nigeria. I think Ghanaians are richer than Nigerians, right? I'm sorry to say that, because they have more of, free screenings. I'm quite aware that there are free screenings in specific locations in Nigeria, but what I'm not sure about is reaching out to the rural settings. Janet, do you have any idea about that in terms of reaching out to the rural settings? I know there are a lot of screening centers in Lagos, Abuja, all the metropolitan cities, but the rural settings, no. I don't think there is any of such. Ilyas, your hand is raised up, or is it on hold hand?
Yes, good afternoon, everyone.
Good afternoon.
Concerning cervical screening in Nigeria, and specifically my location, Kwara State, I can say for a very long time, I have not heard anything about cervical screening. Wow. So I think awareness is a big factor. A lot of people are not aware and they don't know anything about it. Some people don't even know what is called cancer up till now among the elites. Then secondly, the biggest problem is poverty. A lot of Nigerians, because of poverty, they don't even go to the clinic for medical checkup until when their condition is critical. So, yeah, talking about cervical cancer is really something else for such people. So I think there must be, there should be a level of awareness to help in that direction, and maybe if the government will give more effort and put more effort on this, because talking about poverty is only when someone is well fed that he may want to talk about things that will happen to him in the next 10 years or so to come. So that's a big challenge here.
Thanks so much, Ilyas, for sharing that. I agree. And I think there's a part of me proposing that could there be rewards for those that, on-the-go cervical screening in Nigeria. You come for screening, you get you get 500 naira or 1,000 or 2,000. I'm sure people would love to get screened when there's a reward system in place.
Yes,
That part,
actually.
I think, could be factored in low middle income country. Yeah, this okay.
Thank you, everyone. I'm just thinking, I don't think they don't want to do it, but the facilities are just not there. Because at least I practiced in Nigeria for say some years, but I've never seen any period of time that the cervical screening was done for free in my community. So I'm not even aware of any hospital that is doing it for free. So I don't think people do not want to do it, but the fact that there are no hospitals or no free access to it, the incentive may be good to bring them together, but the facilities are not actually there. If there is any, please, I would like to know myself, because I have people back home that would like to advise to go and do it. If there is any in Lagos, please let me know also. Thank you.
Thanks, Abalanle. We need more comment. Yeah, over to you, Professor Dominic.
Thank you very much. My comment is that we have some, but most of the time they are to the elites, just like coming to the
Okay.
university community to
Is it
do
free? Free for
screening.
them?
When, especially those who get grants, when people get grants, they have to do these things. So
Okay.
grants make people to give free cervical cancer screening. So what I think is there is a need, even when such people are doing such screening, to go to the local community. And another thing I want to say is that one of the major challenges is that we don't always think of the local speak English. There is a need to do a collaborative work instead of always using the cities to collaborate with stakeholders, so that the opportunity that are made available should go to the local community. Then, most of the time in Nigeria, when these things are done, they are done let me say, dichotomically, that is based on the just public health people going. There is a need to collaborate. For example, when you have a platform of physical activity for health promotion, there could be a kind of campaign awareness, given health talks, the relationship between physical activity and cancer prevention, cancer management, using the platform of physical activity. I think with that, there could be a way to reach out to people. But when it's just ordinary screening, the transportation to the venue is another problem. So many challenges. So I think multi-platforms will be better to be able to, get people screened or aware of cervical cancer. Thank you.
Thank you so much, Janet,
Yeah.
Professor Dominic. Janet and Layden, are you still on ground? I mean, these are like brainstorming research ideas. I feel we could meet and talk about. I mean, looking at exploring this in LMIC, particularly Nigeria settings, would be a great opportunity to catch up with you both later on. But as it is, you can't agree with me that the level of screening in Nigeria is still, far behind other countries. Ghana is leading from what I can see here in the comment section, then Cameroon as well. But one of us mentioned that in Enugu State, they are actually doing awareness or seminar free and screening test. You pay, but you have to pay. That's the issue. You have to pay. I think what will work in Nigeria setting is you screen, you have a reward. It could be food, it could be money, but just to enable or engage people to leave their comfort zones to get screened. We are really conscious of time and would love to continue with this stuff. But if you have any other comment, let us know. Other than that, Alosh, can you please share your screen so that we'll proceed with the webinar? Yeah, Tunde Falola, please crack on. Over to you.
Thank you very much. In addition to all that has been said, I think the fear of the outcome of the screening makes most women within the rural areas not to go for screening, because at the end of the day, when they are screened and they find out they have this issue of cervical cancer, they may be afraid. You know, among those women, when they hear such things, they think maybe in the next 5, 10 years they will die. So they are always afraid to go. So maybe there is an awareness, the encouragement, all the wither that will encourage them that look, we are not going to face this consequence, just to test you and know whether you have that or you don't have it. And that there are medicine and medications that can prevent it. Maybe that could help also. Thank you.
Great. Thank you so much for that great feedback. I agree with that. I'm just really conscious of time now. But before we end this webinar, I also want to call your attention to the upcoming Congress, which I've mentioned earlier. But for those joining us now or later, we've been having the ALIBSA webinars, which has been delivered online, and we've been funded by the University of West of England, Bristol, to host our first annual Congress. So this is not one-off thing. We'll be having series of this annual Congress. So the first ALIBSA annual Congress will be on the 1st of July. And the theme is stakeholder engagement. We want to understand their health need. We want to know what are the key barriers people from the ethnic minority communities who reside or live in the UK, not Nigeria, what are the barriers they face to access health. So we hope that this will be fed into research ideas, grant writing, networking opportunities. So these are not just the public, we are also going to invite policymakers, care workers, and allied healthcare professionals. So we will communicate the details with you. If you wish to be part of the stakeholders, kindly email any one of us. There is a reward of Amazon gift voucher if you are a stakeholder on this. So please feel free to communicate this within your network. Yeah, so next slide. Or is that all for today, Alosh?
Yes,
Alosh, you're muted.
that's all for today. So that's
Oh, yay.
yeah, thank you everyone. As Fatia said,
Right.
so we are looking forward for all of you joining us at the Congress, and thank you so much for today as well.
Thanks for joining. Our next webinar will be next month as well, which is in June, which is the last Wednesday of the month, and we would have a speaker who would deliver. For now, it's by Dr. Adesope. The topic and the details will be communicated in the future. We have the ALIBSA community. If you wish to join our community, please let me know. You can private chat any of the ALIBSA team. Alois, can you scroll to the previous slides just to show the ALIBSA team? You can private chat any one of us if you wish to join the ALIBSA community. I'm sure a lot of you came through myself or Alosh or Giselle or Deji or Janet. So please feel free to private chat. We also want to end this webinar by thanking Janet one more time for her time. Because it takes a lot of efforts to prepare for this kind of presentation. And to us, this is like the highest we've reached so far, Alosh. We nearly reached 43 participants. So thank you so much. We hope we'll be able to sustain this next month, and we'll see you next month. Thank you. Bye.
Thank you.
Thank you. Bye.
Bye.
Thank you.